Hello and welcome. I'm Dr. David Minter. I'm here to assist you with your critical thinking for your IM 660 course. Today we're going to be taking a look at a case of bradycardia. We're going to talk about the differential diagnosis for syncope. We're going to talk about how to narrow down this differential diagnosis using history, using physical. Specifically, we're going to look for some red flags when it comes to bradycardia. We're going to talk about sinus node dysfunction. We're going to talk about AV node dysfunction. We're going to talk about how to work these patients up and then what to look for on an EKG, specifically related to syncope itself and bradycardia. And then we're going to talk about some treatment under various circumstances. There's going to be a practice question that's going to immediately follow this portion of the video. The answer is all the way at the end after the case is finished. So without further ado, let's get started.
Which of the following forms of bradycardia is not related to sinus node dysfunction? A. A patient that passes out while shaving with a heart rate of 35. B. A runner with a resting heart rate of 45. C. A patient that gets a third-degree heart block after an inferior wall heart attack. D. A patient with atrial fibrillation that passes out when his heart rate suddenly drops to 40.
Chief complaint: passed out while walking. A 68-year-old male presents to the emergency department after experiencing a syncopal episode while walking to the kitchen this morning. The episode lasted a few seconds, and he regained consciousness without confusion or weakness. He describes no associated chest pain, dyspnea, or palpitations, but mentions mild dizziness before the event. Over the past week, he has noticed increased fatigue, lightheadedness, and occasional episodes of near syncope while standing. He had no history of trauma, bowel or bladder incontinence, or tongue biting. He has a past medical history of hypertension, type 2 diabetes, coronary artery disease, BPH, chronic kidney disease stage 3, and dementia. He's had a surgical history of a cholecystectomy. Social history includes quitting smoking 5 years ago, and patient drinks 2 beers daily. Family history is positive for MI and hypertension. His current medications are losartan 50 milligrams daily, metformin 500 milligrams BID, glimepiride 1 milligram daily, aspirin 81 milligrams daily, and atorvastatin 20 milligrams. On physical exam, the patient's noted to have a blood pressure of 128/72, heart rate 38, respirations 18, O2 sat 96% on room air, and temperature 98.6. The patient's alert and oriented but appears fatigued. A cardiovascular exam shows bradycardic rate with regular rhythm, no murmurs, rubs, or gallops noted. The respiratory exam shows clear breath sounds bilaterally. His abdomen is soft, non-tender, non-distended, with positive bowel sounds, and no palpable masses or hepatosplenomegaly. Neurologically, he shows no gross motor or sensory deficits, and his extremities show no edema. So let's start with a differential diagnosis for this patient. Stepping back for a minute, let's actually think about a differential diagnosis for syncope overall. There's lots of different mnemonics for this today. We'll use the, head, heart, vessels mnemonic, so we make sure we don't miss anything. Starting with head, hypoxia, hypoglycemia can cause syncope. Epilepsy is a common syncope mimic. Anxiety, which results in hyperventilation, can cause a patient to pass out, as well as dysfunctional brainstem, which is another name for vertebral basilar TIAs or strokes. Heart attacks can cause syncope. Embolism can cause syncope. It's actually one of the most common presenting symptoms for PE that results in a missed pulmonary embolism. Aortic obstruction, things like idiopathic hypertrophic subaortic stenosis or aortic stenosis or myxoma can cause aortic obstruction resulting in syncope. Rhythm disturbances as well as tachyarrhythmias can cause syncope. Vasovagal syncope, ectopic pregnancy can cause syncope. There's situational syncope, subclavian steal. From an ENT cause, glossopharyngeal neuralgia can cause syncope. It's a rare condition resulting in fainting due to severe pain in the throat, ear, or tongue. Low systemic vascular resistance can cause syncope. This has a myriad of causes underneath it. Things like autonomic causes like adrenal insufficiency, diabetic vascular neuropathy, Parkinson's disease. All medications that cause syncope fall under this category too. This would be your antihypertensive medications, things like beta blockers, calcium channel blockers, ACEs, ARBs, vasodilators, diuretics, alpha-2 agonists, nitrites, antipsychotic medication via alpha blockade or by QT prolongation can result in syncope, just like antiarrhythmics can cause syncope. Antidepressant medications like TCAs or trazodone can cause syncope. Alpha-1 agonists like tamsulosin can cause syncope. Dopaminergic agents like levodopa and phosphodiesterase inhibitors like Viagra can all result in low systemic vascular resistance. And then last but not least is sensitive carotid sinuses. So to help narrow our differential diagnosis for our syncopal friend, we should probably ask them some additional questions to try to tease some of this out. For vasovagal syncope, we could ask if there was any emotional context to this for fear or pain, or if the patient just saw blood. For orthostatic syncope, we should ask about change in position, if this was a stimulus. GI stimulation can also cause syncope by increased parasympathetic tone. Situational, if this was associated with coughing or sneezing or laughing or micturition or other GI stimulation. Was the patient touching their neck recently? That can induce a vagal reflex, which is carotid hypersensitivity. Yeah, has there been any changes in the patient's medications? Anything new? Any increased doses? Are they having any cardiac symptoms around this? Palpitations, chest pain, shortness of breath? Have they had any recent changes in volume, meaning decreased access to water? Have they been having GI bleed, diarrhea, emesis? Was there any shaking associated with the syncopal episode? Patients can have shaking of less than 15 seconds at presentation or right after the event. Sometimes this is just myoclonus, as opposed to if it's a longer episode, this may make you think seizure rather than syncopal episode. So some big things we could ask about, and these are red flags associated with syncope. So if they have syncope plus something else, like if they had headache at onset, then we would think about subarachnoid hemorrhage or signs of increased intracranial pressure. If they had chest pain, we would think about dissection or MI or pulmonary embolism or maybe even tamponade. Aortic stenosis can also have chest pain, pulmonary edema, and syncope. Those are the three most common symptoms that present with aortic stenosis. Shortness of breath would be another red flag. We would think about ACS. We think about arrhythmia, MI, tamponade again. If the patient had palpitations associated with their syncope, we would think about arrhythmia. If they were vomiting around the episode, we might think about vasovagal, which would not be that big of a red flag, but really ACS would be a bigger concern, meaning acute MI. If the patient had acute onset abdominal pain or back pain, we'd think about ruptured aortic aneurysm. We would think about GI bleed. If it's a female, maybe we think, and in the right age, we would think about ectopic pregnancy. Just like if the patient presented with vaginal bleeding and syncope, we would think about ectopic pregnancy. Getting back to our patient specifically, if we're going to attribute this to the patient's heart rate, so if we have syncope plus bradycardia, how do we approach this patient differently? So our differential is going to be thinking about sinus node dysfunction, which is failure of impulse generation, and then also atrioventricular nodal dysfunction, which is failure of impulse conduction, specifically down the AV node. Sinus node dysfunction is associated with persistent sinus bradycardia, ectopic atrial bradycardia, otherwise known as wandering pacemaker, chronotropic incompetence, things like sinus arrest or pause, and then tachybrady syndromes. To look into the specific causes of sinus node dysfunction, we would again want to ask them about ischemic symptoms like angina, shortness of breath, if they had carotid stimulation, as this can result in sinus dysfunction, meaning hypersensitivity. If they had a head injury recently, this would result in Cushing's reflex, which would result in bradycardia, as well as we should scan their chart looking for history of collagen vascular diseases or maybe infiltrative diseases. For atrioventricular node dysfunction, these are things like first, second, and third degree heart blocks. Again, we would want to ask about specifically acute onset, like STEMI, as infarction of the right coronary artery causing an inferior wall of MI can result in second and third degree heart blocks. We'd want to ask them about any travel history for things like Chagas disease or if they've gotten tick bites recently. But for either sinus node dysfunction or atrioventricular nodal dysfunction, in either of these situations, we would want to ask about vagal stimulation as it can cause both of them, as well as there's multiple different medications that can cause either dysfunction, as well as thyroid disease too. So we'd want to ask if the patient had any fatigue, weakness, weight gain, as a possible etiology of bradycardia. So focusing on physical exam for our patient, the main thing we'd want to focus on would be signs of hypoperfusion. If the patient had altered mental status, if they were extremely short of breath, if they had pale skin, if they, the signs of hypoperfusion to the brain, because this would require immediate intervention. More subtly, for a patient with syncope, we could do things like orthostatic vital signs, which would If positive, it would mean there would be a fall in, 20 millimeters of mercury of systolic or diastolic, I'm sorry, 20 millimeters of mercury in systolic blood pressure and 10 millimeters of mercury in diastolic blood pressure upon standing for 3 minutes. We'd want to really listen to the patient's heart carefully, listening for signs of murmur, muffled heart sounds for tamponade, making sure the rhythm's regular. We may want to test the patient for things like chronotropic competence. Again, if they're only mildly symptomatic, this would involve getting them up and walking them around the room and measuring their heart rate to see if it increases with the additional stimulation and increased oxygen needs of ambulating. We'd want to look for any neurological changes. Things like stroke can mimic syncopal episodes. Maybe if the person had arm weakness or confused after the event, then maybe we'd want to think about postictal state or possibly a Todd's paralysis, which would be seizures masquerading as syncope. And what initial treatment should we start on this patient? Well, we're going to need to place them on a monitor. We're going to need to get IV started, labs. Maybe we'd want to give them some fluid initially, depending on how symptomatic they were from this. This would screw up your orthostatic testing if you did this beforehand, so maybe you'd want to test orthostatics first. But initial interventions for this really depend on how symptomatic the patient is. If they're highly symptomatic, like in shock, they require immediate intervention. If they don't have a pulse, they would need things like CPR. But like I said, it depends on the presentation. And what workup should we order for the patient? Well, the most important thing is going to be the telemetry strip or EKG, more specifically. When examining a patient with a syncopal episode, again, there's lots of mnemonics for this, but A, B, C, D, E, left, right is a mnemonic. It helps you remember what you're looking for on an EKG, specifically related to syncope. So the A would be AV block, the B would be Brugada pattern, the QTC changes for C can result in torsades. We would look for D, a delta wave. For Wolff-Parkinson-White, we would look for E, an epsilon wave, which is an arrhythmogenic right ventricular cardiomyopathy sign. For left, we would look for left ventricular hypertrophy, which can be signs of cardiac outflow impairments from hypertrophic cardiomyopathy or aortic stenosis or coarctation. And then for the right, we would look for signs of right ventricular strain, things like S1Q3T3 that may indicate a sign of pulmonary embolism. So after we look at our EKG, then we probably want to do some lab work. So what kind of workup should this patient get? We'd want to do a complete blood count looking for severe anemia. We'd want to do a basic metabolic panel. This would look at potassium. It would look at calcium for electrolyte problems that may result in syncope or conduction abnormalities. We'd want to look at their BUN as a possible sign of pericarditis, which can also cause bradycardia, more specifically myocarditis. We'd want to look at the patient's glucose level, as hypoglycemia can be a mimic of syncope. We would probably want to do a thyroid screen for the bradycardia that the patient has, making sure they don't have myxedema or hypothyroidism. We'd want to check a troponin additionally to see if there's any signs of cardiac ischemia associated with the bradycardia. So what do we get for our patient? We've got a CBC, which doesn't show any significant anemia. They do have a little bit of a white blood cell count. We have a basic metabolic panel that shows a hyperkalemia. Their BUN to creatinine ratio is high. Their creatinine is 2.1. They had CKD stage 3. We'll say their baseline creatinine's 1.8. So this means the patient has an acute kidney injury. The glucose is a little bit on the low side of 80, still within the normal range, calcium 8.2. So hyperkalemia, AKI that's present here, specifically in our patient, we would probably need to stop the losartan that they're on, as that can cause hyperkalemia. Maybe that's a cause of the bradyarrhythmia that they're having. The glimepiride that the patient's on is also renally processed for their diabetes. So with the acute kidney injury, they'll build up more and more of this in their system to the point where they become hypoglycemic, which could be a mimic of the patient's syncope. We want to check some other labs, TSH, which is also within normal limits. There doesn't seem to be any elevated troponin level, indicating a non-ST segment elevation MI, and their magnesium seems normal. So let's run through a couple of scenarios. So let's say our patient has the following EKG. Why don't you take a minute, feel free to pause the video, look over the EKG, and see which diagnosis you can come up with. So we have a first degree AV block that's present here. The heart rate's about 50. PR interval's 206, so long with a narrow complex QRS. So first-degree AV blocks don't normally cause significant enough bradycardia to cause symptoms. Since the heart rate's already 50, probably we would look for other causes of syncope. The first-degree AV block can be a red herring that people get focused on, but since it doesn't generally result in symptoms, we would want to look for other causes. They would probably need to avoid AV nodal conduction blocking agent since their heart rate's 50, but otherwise not much else to do here. So let's run through another scenario. Let's say this is the patient's EKG. Take a pause, read it over carefully, see which diagnosis you can come up with, and then I'll give you some answers about it. So this is a first-degree AV block again, with some frequent PVCs, but you'll notice this is a really extreme first-degree AV block. The PR interval is calculated out at 328, so it's just enormous. So this can be a sign of pseudo-pacemaker syndrome, which is rare. It involves a markedly long PR interval greater than 300 milliseconds. It results in contraction occurring when the atrioventricular valves are closed, which can lead to an increased wedge pressure and decreased cardiac output. If the patient had this extreme PR interval and we thought this was causing symptoms, meaning the patient's syncopal event was attributed to this block, this can actually be an indication for a pacemaker. But generally, first-degree AV blocks don't result in pacemakers. Here's another scenario for you. Take your time, look everything over, pause the video, make any diagnosis that you need to, and then I'll give you some answers. So what we have here is a second-degree AV block. It's specifically a Mobitz type 1 or a Winkie-Block block. So it's a little bit easier on the rhythm strip. You can see at the bottom the non-uniform prolonging PR interval that eventually results in a dropped QRS. If you also want to look carefully at this, you'll notice that there's some ST segment elevation in 2, 3, and AVF, and some reciprocal changes in the precordial leads. So this is a patient that's having an inferior wall STEMI. So the bradycardia or the PR interval, the second degree block that the patient has, takes a back seat to the fact that they're having an acute heart attack. Since the right coronary artery is what feeds the inferior wall, this can also result in second and third degree heart blocks. The treatment for all of this is treating the underlying cause. If the patient's heart isn't getting enough blood flow, their SA node or their AV node, they would need to be rushed for a cardiac catheterization for possible stent placement. Then after the fact, after they've got blood flow, they could reassess to see if the block is still present. Here's another scenario. Again, take your time, look over the EKG, pause the video if you need to, and then we'll talk about some answers and what we found. So this is a second-degree AV block, again, with a heart rate of 38. In this case, it's a 2-to-1 AV block. This is a case where the PR interval is uniform before every QRS, and then it's dropped. Since the block is happening every other beat, there's not enough PR intervals to see if it's a Mobitz type 1 or a type 2. It's narrow-ish. This usually means it would be a type 1 Mobitz block, but the QRS is actually calculated out at 114, so that's not really that helpful. Wide are usually associated with a Mobitz type 2. The block is not high degree, meaning that less than 50% of the atrial impulses are resulting in ventricular contractions. A high degree block means that there's greater than 3-to-1 ratio for the block. So the treatment for this patient depends on how symptomatic they are. So hypothetically, if they were completely asymptomatic, we would do a workup for them, like an echocardiogram. If for some reason during a conversation with them, if we were to tease out anything about possibly having daytime somnolence or falling asleep easily or cataplexy or not feeling rested when they wake up, then maybe we would want to send the patient for OSA testing as compliance with CPAP reduces significant bradyarrhythmias in 72 to 89% of patients. So if they were getting admitted for this, they would get their electrolytes maximized, meaning normalized. They'd be taken off any AV nodal blocking agents. If we didn't find any reversible causes for this and the patient's symptoms were attributed to this bradycardia, then it could result in a pacemaker placement after the workup was completed. So this will be the last patient scenario. Here's your EKG. Take a few minutes, look it over, see which diagnosis you can come up with. So here we have a third-degree heart block with a heart rate of approximately 30. So you can see there's no correlation between the P waves and QRSs, and there's uniform intervals between each P wave, which you can see marked on each line. This one, the P wave's kind of buried in the end of the T wave, but you can see how it marches out, and this isn't correlating with a QRS each time. So what we do for this patient, so the treatment depends on the acuity of or the severity of symptoms. So if the patient had no pulse, we would immediately be initiating CPR. If they were found to be hypotensive or unstable, we could try some atropine on the patient, blocks the parasympathetics. Hopefully the heart rate would pick up. Additionally, for sympathetic stimulation, we may want to start the patient on an epinephrine drip or a dopamine drip. Depending on how quickly that can get set up or its effectiveness, the patient may require transcutaneous pacemaking or even transvenous pacing. So transcutaneous is much quicker, just involves putting pacing pads on the chest, setting the machine to a heart rate of 80, just really faster than the person's beating currently. And then you slowly turn up the gain until capture is seen. Transvenous pacemaking is a little bit more complicated. It involves floating a wire with a balloon on the end of it into the heart via either the right internal jugular vein or the left subclavian vein. So let's assume the last scenario with the third-degree heart block was our patient's scenario. We gave them some atropine. It didn't really change the person's heart rate. We put them on dopamine peripherally. While central venous access was obtained, this involved putting a cordis, which is basically a central line that's wider and shorter, doesn't have as many lumens. We put that into the right internal jugular vein, and we ended up floating a transvenous pacemaker, which was very finicky to place. Cardiology ended up having to come in to assist us with that because it's hard to maintain capture. We fixed the patient's potassium level without any changes in the underlying arrhythmia. An echocardiogram was completed showing a 35% ejection fraction. They were concerned about an ischemic cardiomyopathy, so on day 2, the patient completed cardiac catheterization, which showed non-obstructive CAD. So the patient ended up being diagnosed with a non-ischemic cardiomyopathy. As all reversible causes had been explored, the case was discussed with an electrophysiologist, and a permanent pacemaker was placed.
Answer. Third-degree heart block, option C, is caused by a failure of conduction between the atria and ventricles, usually due to ischemia of the AV node or his Purkinje system. The sinus node may function normally, but its signals cannot propagate to the ventricles. Option A. Patient who passed out while shaving likely has carotid sinus hypersensitivity, a form of sinus node dysfunction triggered by external pressure on the carotid sinus. This results in an exaggerated vagal response, leading to sinus bradycardia or sinus pause. Option B. A runner with a resting heart rate of 45. This represents physiological sinus bradycardia, common in well-conditioned athletes. Enhanced parasympathetic tone slows the sinus node's firing rate, but it is not pathological and related to sinus node physiology. Option D. A patient with atrial fibrillation that passes out when his heart rate suddenly drops to 40. This is a hallmark of Tachy-Brady syndrome, a subtype of sinus node dysfunction. The sinus node fails to maintain an appropriate heart rate after a rapid atrial fibrillation episode terminates.